would say that familiarity and that shared experience is lacking. And that's why it doesn't seem as real. It just seems foreign. I'm not saying that non-binary isn't a real thing. I'm just saying it seems too foreign. And unless if we get those experiences of exposure to non-binary people, their values, and also how we can have certain shared values, then I think it would just be too premature of us to talk even about medicine, right, in some level. Because there's already assumptions about the binary being brought into non-binary treatment, when we should be talking about just like the social implications of being non-binary before even maybe medicine. Does that resonate a little bit?
I think I just disagree.
Yeah. Hey there, folks. Welcome back here to John Chen Out to the World. Thank you so much for joining here for another episode. I am John, your host, and today I have an amazing guest with incredible research in the topic of gender science. Today, I am joined here with Stef Shuster. They use they, them pronouns, and they are a trans professor over at the sociology department, working alongside in the department of Lyman Briggs. So their topic of interest is the science of gender, and then also the medicine and practice of how we treat gender. Today, I have the pleasure of sharing their book, Trans Medicine, The Emergence and Practice of Treating Gender. Stef, thank you so much for joining here today.
Yeah, thanks so much for having me on.
Yes, of course. And it's crazy because we were just talking earlier about this. I had the pleasure of somehow being ghostly in your class. Like I was there in your class, but I never had an actual encounter with you. But I had a friend who was a student of yours, and we did a little interview, talked about how I was queer and Christian, that sense, and then also sharing about my experience within your class. What class was that?
Ooh, I think it might have been the science of sex and gender.
That makes sense.
Yeah. So in that class, we just talk we get into more like scientific values and norms, and how the scientific community kind of a lot of times makes things up when it comes to sex and gender. So
totally. And I see that peeking out in your book as we'll go through. So can you give a brief overview of how you got into this area of sex research and gender trans research in general? You yourself are trans and you're non-binary. How did that come about? And growing up, what was that like? Where are you from?
Yeah, so I grew up in Louisville, Kentucky, and at that time I did not identify as trans. It was the late 90s when I was a teenager in Louisville. In fact, I don't think I even heard about trans people until the early 2000s, once I got to college. So growing up in Louisville, I mean, I identified as queer. I was in a high school that had, I think it was like 2,000 students, and only 4 or 5 of us were out. Because at that time it just felt so fraught and stigmatized, But, I went to college, and I think a lot of people have this experience where they get into classes and they start learning about new people and identities and ways of thinking. And I think I took a sociology of sexuality class, and for the first time ever realized that there were people who were trans, and I kind of filed it away. Then I went to the Michigan Women's Music Festival because I'm assigned female, and I at that time I was really invested in like a queer feminist identity, and so I was like, this music festival sounds great. It's going to be a week of camping and musicians and workshops and meeting other cool feminists. And I guess what I didn't really think carefully about, or didn't understand until I got there, was like each day that passed, I kept feeling more and more like something does not belong. And then I finally was like, oh, it's me. I don't belong in this space. How odd. I wonder what, like, that just seems really weird. So I kind of packed that home with me, and over the next year, started taking more classes with that same sociology professor and asking her for readings. And I realized like the reason why I didn't feel like I belonged at the women's music festival is because I don't identify as a woman. Like,
Mhm.
and I noticed that I started, and I don't want this to sound um, like misogynistic. It's more just about, for
No,
me, in my experience, when people would be like, "Hey, lady," or like, she, I started cringing, and I was like, I think that's pretty strong evidence for me that like that label just does not fit anymore.
right.
Um, yeah.
Yeah, thanks for sharing that. I know that
Hmm.
everybody's path toward their diagnosis of gender dysphoria is different. And
Hmm.
did you always feel like that? Like growing up, were you always kind of like a tomboy or stereotypical type of tomboy, or
Oh
um,
yeah, oh yeah. I mean, yeah, like softball and all that stuff. I played in punk bands. I listened to a lot of Riot Girl music. But like, I actually never felt dysphoric about my gender.
like growing up? That is.
I mean, even
Wow.
identifying as trans, yeah. Like,
Yeah.
it didn't feel. It felt more. I don't know how to explain it. Like when I read about gender dysphoria and people who feel that way, it's like just this incredible discomfort, um,
Mm,
and like this, kind of urgent sense of like this has to change.
mm,
Um, and while I maybe didn't feel comfortable in my skin, I I just kind of felt like being a girl does not make sense to me. And so what might, so it was like it just never felt for me. And I know that like it's real. I'm not discounting like gender dysphoria is real, but
right.
for me it just
Totally.
doesn't feel quite like a part of my experience. So
I see. Great. I think that that really does give us a backdrop to what your book is also contending with, because in our culture we have a binary sense of gender, most overall, binary sense of gender. And we're going through this process since the sexual liberation of the 1960s of questioning, even Simone de Beauvoir's book, The Second Sex, we're questioning what does it mean to be a woman? And in
mhm,
other spaces, what does it mean to be a man? Maybe as a response to it.
mhm,
And what I find really puzzling is this notion of how, again, our gender identity is something that we do experience viscerally, right? Emotionally and spiritually, in some sense, right? Like not materially, that is. And then you have the material world where we're trying to encapsulate, categorize, really dissect, gender into these binary norms. Which, again, for whoever's watching, we can kind of appreciate the fact that yes, sex has a relationship with gender on some level, or sex has really informed traditionally what our notions of gender should look like, or perhaps even different parts of our socio-political landscape, religion, that definitely has a part to play as well.
mhm,
Namely, myself being a Christian, I think the church and the teachings of the church, the Bible, have given us an idea of what male and female should be, even though it's kind of elusive. So when we're
mhm,
talking about science, though, when we're talking about our culture, you have a stake in the matter because you are not someone who fits the binary really well, not neatly at all.
mhm.
And when you're going to this research, because you have transitioned, how does that how does that broaden, I think, the landscape that we right now have in trans medicine, right? Who are the people that were doing trans medicine? Who are the people that historically practiced trans medicine and transitioning? And we'll use trans, as you use in your book, as something that's kind of all encompassing, because the term itself has changed from gender identity disorder to now gender dysphoria. Again, not everybody who has gender dysphoria chooses to transition in some way, socially or physically. But historically, you talk about it in your book. And how did we get to this point here today in treating transgenderism, or the gender dysphoria label?
I think I started identifying as trans maybe like, let's say 2002, 2003. And I got to Iowa City to start my PhD program. I knew I wanted to be a sociologist. So I got to Iowa City in 2007, and I had been thinking about top surgery. Not like I hadn't even. I was like, I never want to be on testosterone. I just want top surgery. And so I started asking around. Like moving to a new town, it's hard and stressful, and like I had grad student insurance, so like I needed to find a doctor, um, and so I felt committed to finding someone who was knowledgeable about working with trans people, um, and so I started asking, like, trans people and anyone I could find, like, where are the providers who work with trans people? And people were just like, that doesn't happen. Like, we don't. There is no one here who does that. I guess this is all to say. I'll just kind of like wrap up this part of the story. I really had trouble finding people, providers who wanted to work with trans people, or even those willing to.
Right.
But the more I asked, I think the more word started getting around, like, hey, there's this need to have at least, can we get one provider who will work with trans people in this town? And so I finally started meeting providers who are like, I have had trans patients. I've always felt really uncomfortable. I don't feel like I know what I'm doing. And I was like, that's cool, because I'm starting a group and we're going to start offering workshops and we'll train you. Like,
Mm.
we can't train you on, how much hormones to administer, but how to be like a decent person to trans people. And so in doing a lot of that healthcare advocacy work, I really started thinking about, um, that there seemed to be something sociologically interesting about this idea that doctors who are supposed to be experts and knowledgeable were so quick to say, like, I just don't know anything about this, like, I just don't know. And this would even come from, like, gynecologists, and if you think about it, gynecologists work with hormones all the time. So so there's this one interview where, this gynecologist was really describing this challenging process of just stumbling through. And I was like, I take a teach me tact when I interview people. And so I was like, help me understand, because it seems like a little confusing to me. As a gynecologist, you prescribe estrogen and progesterone all the time. So why is it different for trans women and getting them started on hormones?
Right.
And she was just like, I could see it. She was just like, I never thought about that before. Like, and I'm like, I just, tell me more about that. So
Yeah.
that really kicked off the research, because I wanted to learn more about the challenges that providers experienced and also how they manage those challenges, as like expert knowledge producers.
Right. That's a really fascinating point because you do bring up in your book how people were uncomfortable with the fact that hormones are being used in trans bodies versus cisgender bodies. So cis being people who are, you know, heteronormative in the sense that they align with their, not even heteronormative, but align with their sex assigned at birth. So their gender aligns with their sex.
Mm-hmm.
And that is somehow different from trans bodies. And I think ontologically, I see them as the same, right? Like they're physiologically intact. I don't think that there's somehow this magical anomaly that happens when you're pre-transitioning. You're somehow already trans in some sense physically, because being trans by definition is a distinction between your gender identity, right? Whether you're non-binary or a trans male, trans female, you feel feminine, more masculine, and your sex, your biology, physical body presentation. So I think when I read that, I'm like, well, how do people go about treating trans individuals with hormones, and the clinical science, the treatment trials, the trials on the science of hormones still isn't really as conclusive, it seems like, from your work.
Mm-hmm.
And how was it like 20 years ago? Obviously, it's really, really depleted of any form of like really solid uh, pathway as to how to treat with hormones on trans people.
Yeah, I mean, so in my book, I talk about how trans medicine really kind of takes off in the 1950s. And if you go back to, and I went down to the Kinsey Institute archives at Indiana University and looked at correspondence between providers. And a lot of times it was like, I have this trans patient. It actually sounds a lot like the providers that I was working with, right? I have this trans patient and I have no idea what to do. How much estrogen should I put this person on? And if you look at those doses, back then it was like 4 times the amount of hormones that people are on right now, which actually presents a lot of health risks for people to be on like that much estrogen or that much testosterone. So a lot of it was kind of, you know, learning by doing. And over time, I think doctors finally figured out that trans people did not need to be on such high doses. But like, trans medicine, if anything, is really marked as an area of medicine where where providers are learning more or less off the cuff and, like trading information with each other. For a long time, it was an informal basis. Now there are professional associations. But if you think about it, like, we're talking about an area of medicine that's been around for at least 70 years. And to not have strong scientific data to assess the long-term effects of hormones, it's like that number. It strikes me. I find it really striking. Like
Right.
70 years,
We
So
shouldn't trivialize that. I mean, I think people kind of overlook that within broader society and say, like, as you said in the very beginning, that people were coming to you and saying, like, no, trans medicine is really robust and we're doing really well and progressing and so forth. And maybe we are progressing, but even in your book, you say that this is not a linear type of progression, right, that's taking place, but there's actual levels in terms of the endocrinologists, the psychologists, and the feuding battles that have taken on, in various forms throughout the 21st century and 20th century.
mhm.
Now, tell me a little bit about how trans people were treated back then, as you detail it in the 20th century, because there's different phases in how people have used certain types of words like tricksters and someone who is a legitimate trans person.
Mhm, mhm. Yeah, I mean, if you open a lot of historical books on trans people, they often start in 1952, which is when Christine Jorgensen became one of the first like internationally um, known trans women. And I don't discount that she was incredibly important, and I honor how difficult it must have been to be Christine Jorgensen, right? Like intense media scrutiny. Her biography is getting blasted all over the newspapers. But what she also did was she kind of became a model patient for how medical providers understood what a so called proper trans person should look like and sound like. Christine was white, middle class, hyper feminine, came from a respectable family, and wanted to, in some of the interviews, like she talks about she wants, she desires to become a woman so she can become a housewife and all these things. And
Hmm.
it really set up an incredibly difficult standard because doctors, and there were only a handful who were working with trans people in the 1950s, but that is what they thought of as what it means to be, at the time they used the language of transsexual, right? Um, and so if you didn't fit within that, you, you likely would be denied care, right?
Would you
Because
say
it
you yourself then be denied potentially the care in that generation?
Yeah, yeah, absolutely. So, doctors were, and they were using a lot of, I mean, this is where I think at one point I talk about where science and values meet, right?
Mhm.
Because they're really understanding trans people through the lens of subjective ideas about what it should mean to be a trans person and why like how someone identifies themselves as trans, and what they should look like and what they should be doing with their lives and their bodies. So there's just like these, and like being in the archives day after day, like it was actually quite difficult to keep reading all of these letters because some of the things that people said were they were gross and reprehensible. Like
Right.
trans people are lying at all costs to be able to obtain hormones. And, this one person arrived penniless and just expected me to give them care, and it's just like all this, like, I don't know. But they also were incredibly fascinated with like the sex lives of trans people,
Um,
which, makes sense because the scientific community has often been fascinated with people in oppressed groups and like what their sex lives are like and reproductive matters, right? So
Right.
I do think there's links between how the scientific and medical establishment treated women's body, like cisgender women's bodies in the 50s, and also trans people's bodies in the 50s. So yeah.
Yeah, that's fascinating. I was listening to John McWhorter, and he is a Black academic, a linguistic, and he wrote a book recently about certain cuss words like and so forth. And these words typically are centered around sex norms and what is considered abnormal, right? Like words maybe used in the bedroom and words that are used in certain specific places. These words in themselves are not categorized by the lettering and the phrasing itself as cuss words. But
Mm-hmm.
because they are related to race, even like the N word, right? He uses that example. These are sacred in some sense, right? Like cuss words are somewhat sacred because they're used to pronounce some type of passion or some type of anger and resentment and feeling towards a certain group or a certain activity or behavior.
Mm-hmm.
And I think when we're talking about, as you have said, about sexuality, sexuality is something that's always been taboo in many cultures, right?
Yeah.
In especially Western Christian contexts, I think you have certain types of development, say in the Victorian era, as Foucault wrote about, the repression of sexuality, where people, have their collars tightly buttoned up, and you will not see a sliver of flesh under your big, huge dresses. But we do have the need to talk about sex. Everybody does, and this is what I think is also currently happening right now in the idea of how gender relates to sexuality. This is something
Mm-hmm.
that you write about in the early 20th century, how people didn't really find any need to transition for the sake of being apart from the binary, right? A very masculine or a very feminine.
Mm-hmm.
But you had to transition to be the ideals of the society's sex, being very feminine and very masculine. Passable, right, is a term that's used. And anything that's under the category of in between, ambiguous, then you're not actually committed to transitioning. You're not actually committed to getting better. So
Mm-hmm.
I have a quote here from your book. This is the main, I think, question and crux of what we're dealing with as psychologists, practitioners, endocrinologists, and so forth. You state in page 79 of your book, Transmedicine. Is the goal of treatment to bring the mind into alignment with the body or to change one's body to bring relief to one's mental health state? The answer to this query has never been fully resolved in transmedicine, as physicians and therapists continue to disagree with each other about who should have authority to decide when a person may begin medical interventions or what circumstances should prevent a person from obtaining gender affirming care. As a result of the redefining the diagnostic code for what is now called gender dysphoria and outlining the appropriate sequence of steps a person should follow before being granted access to gender affirming care. This is really what you're trying to delve into. How are
Mm-hmm.
we improving trans medicine? Does it need to be improved? And what would you say at this point, given that there's still a ambiguity, as we'll get to, an uncertainty about where we're going as a medical establishment, as a society, looking at trans bodies, at trans lives, there is an innate assumption about the binary, right? And what that looks like. And
Mm-hmm.
I personally believe in the biological reality of sex. I believe in male and female and intersex as well. We can obviously talk about how prominent, intersex experiences are and what that looks like. It's a bit convoluted, but most people are male and female by birth. And then how do we present ourselves with a psychological reality of gender identity, right? And how that's socialized, how those behaviors are actualized. Because for myself, I do believe that sex has a role in gender, right? John Money, who is a psychologist and practitioner who you brought up in your book, talks about how gender and sex are completely, you know, indifferent to one another in some sense. But I think through his failed procedures with various types of intersex individuals and David Rayner, who was basically castrized because they had a bad experience with circumcision at a young age. That caused them to, under John Money's taxonomy and his procedures, to socialize the boy who has this ablation of his penis to go into the female role, so that, it's simple enough. You just nurture your way
Mhm.
for this boy to become a female. But the thing is, we saw that as a failed experiment because they still developed boyish tendencies. And so there is a sexual component, a sex-based component to gender. And how is this being played out, do you feel like, right now, as we're moving away from the 1960s and even prior
Mhm.
to the modern age of medicine? How is gender dysphoria being diagnosed? And can you tell me about, like, how a typical patient, say if they're 12 or if they're 25, how they're coming into the medical space and office, and if they're seeking answers to their gender dysphoria or their discomforts, what would that look like? What takes place?
Yeah, yeah. So, I mean, in some ways, the treatment steps are not all that different than they were in the 1950s and 60s. But I think there are some key differences, right? So if we just keep in mind that in the 50s and 60s, doctors were more or less just making it up as they went along, and then that became like canonized as this is the way to do it. So, back then, a trans person would go to a primary care provider who would then send that person to a therapist for mandated 6 months of therapy. They had to live for, I think it was 1 or 2 years, as if they were already transitioned without the aid of medical interventions, like a test. And then eventually the therapist would sign off and the person would go back to the provider and they'd be able to start on hormones. um, in the 90s and into the 2000s, that still was the treatment. Like those were the steps. And it really seems like just in the last 10, 15 years, um, therapists in particular, I think, became resentful of the role that they were playing in trans medicine, right? So they were brought into the conversation in the 50s and 60s as a way to assess a trans person's claim to being trans. And most therapists, like the ones that I spoke with, they talked about how they resented that because as therapists, it really is antithetical to their training. Like as therapists, one person said something like, in no other areas of my practice do I give permission to my clients. Like that's not what therapy is about. And so usually what happens now, but like where it gets hard, I think, in trans medicine is that because there's no formal training, right? A lot of people will have a random trans person come to their clinic and then they search around and they're like what do I do? And but sometimes they find old information. So like right now, these clinical guidelines that kind of outline the steps say that therapy is not required for hormones. It's recommended, but it's not required. So if someone goes to a doctor, technically they could start on hormones. I think most providers still feel enough uncertain that they're like, I would like you to go speak with a therapist. But like, yeah, so it's just, I think it gets messy because there's not a blood test to confirm if you are trans, there's not, and even like the psychological tests that they've tried to come up with, like they don't work, and they definitely don't work right now, right? So
Right. So you're saying
um
the DSM-5, like the diagnostic criteria for gender dysphoria?
yeah, I mean, if you look closely at those criteria, they really still insinuate that and this is like air quote, a real trans person is someone who has always known that they're trans since they were a little kid and they wanted to play with the opposite genders, or maybe they say other gender now,
Right.
like the other gender's clothing and toys. And, there's all this focus on like binary transition from boy to girl or girl to boy. And meanwhile, in the last decade, there's just been like an explosion of people who are like, I identify as non-binary, and
Mhm.
yet I still want to be on hormones. And the medical establishment has once again been
Right.
they freak out and they're like, oh my God, you know, like I don't know what to do. Like,
Well, yeah, I think at one point, one of the practitioners um, you bring up says that, we're talking about gender dysphoria and we're trying to figure out how to treat trans individuals. And then you bring in non binary. We're just like, whoa, like that's crazy.
mhm,
And I think generally as a layman, when I'm hearing that, I'm like, yeah, like non-binary, is that just kind of like a social category? Is that in itself an illness? Because when you're talking about practitioners, when you're talking about medicine, what we classify as illness does not obviously demean the individual as lesser or uh, somehow a strange creature that is just devalued for whatever reason. I think people can do that. People can devalue someone for having schizophrenia. People have devalued people with homosexuality, which was deemed a mental condition, right,
mhm.
in pre 70s. So obviously, gender dysphoria, if it wants to be treated, has to be an illness, though, right? So, I mean, is that the argument? And what do you feel like non binary would pose a threat to the establishment of gender dysphoria? Because obviously they don't go hand in hand. And I found that other people don't know how to answer this question.
Yeah, yeah. I mean, I think where non-binary people present a number of challenges to providers is that, like even though there's not a lot of clinical evidence, like there's a lot of clinical experience that is accumulated in trans medicine. And I think a lot of medical providers were able to justify working with trans people because they had some knowledge that trans means you change from woman to man or man to woman. And, like the way that providers talk about all of their uncertainties about non binary people, it's like you could pick up that narrative that providers are offering, change up a couple words, and it looks like what the 1950s providers were talking
Right.
about, right? Like all of
Shared
these.
assumptions.
Yeah, 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 absolutely. And like, I think it's because the medical way of understanding trans was always premised on from one to the other rather than another gender.
Right. Well, how does one change it to another gender besides male and female? Being non-binary, I think it's still perplexing how, because I think there's an archetypal story or narrative, within the masculine and the feminine, because we think about our mother and our father, right? There's a
Mhm,
sexual component to it that's millions of years old. So how can we socially create and medically create another gender? How do you find how is it substantiated? Because I think people are going to write this off and say this is just a trend within our current society. Maybe a very I'm not saying that it's just kind of a fad or anything, right? But
mhm.
there's a reason for certain trends. There's a reason, maybe a good reason for certain trends too. Like what do you think the non-binary experience as someone who is non-binary would qualify medical treatment? But what
Mhm.
part of that experience would qualify other than, would you compare it to someone who's just seeking plastic surgery? Would you compare it to someone who is just trying to get access to hormones because it does sometimes, as people from, say, the Peak Resilience Project, which is a number of adolescent young adult girls who transition to become men and then detransition, they have stated that testosterone does make them feel better, and we know that from other studies like Lisa Littman, we have heard of that as well.
Mhm.
But I don't want to brush it off as a fad. Do you believe that this is something that really needs the medical establishment to treat non-binary? Why?
Yeah, I mean, I think the same reason why I think like I I have thought a lot about why is the medical establishment involved at all? And I think it really is because they're offering things like hormones and surgical interventions, and therefore it couldn't be like you can just go to, your local pharmacy and pick up some testosterone.
Yeah.
But I don't see any difference between why trans people, like the reasons for why trans, like binary trans people and non-binary, like it's about people's identities and what they,
Mm.
like how they imagine their own
Self.
bodies, yeah, and their selves and what that looks like. So,
Right.
like some non-binary people uh, might not want any medical interventions, but some might want to be on just a little bit of testosterone just to like drop their voice a little bit and maybe to stop menstruating,
Yeah.
because maybe for them, how they understand their non-binary identity is like not menstruating. But I don't, I guess conceptually, I just don't really see much of a difference between the question of why would we offer hormones and surgeries for trans people compared to non-binary people. Like
Right.
it just,
Right.
um,
I think my response to that would be I'm trying to think what maybe some medical authorities and people would say. And I think there's this obvious conservative appeal that we need to be able to help young individuals make decisions that they can't make 10 years down the line, like really see through, which is
mhm,
their fertility, right? If they
mhm,
want to have a family one day, if they want to have children one day, taking hormones can really exact them exactly from that, right? Exact them
mhm,
from the possibility of having children. So if a man chooses to become a woman and has a removal of the testes, what was that term used? Is the
uh,
orchid
uh-uh.
orchidectomy or
Yeah, or
yeah,
orchiectomy.
oh, orchiectomy. Thank
Yeah,
you,
yep.
orchiectomy. Or if a woman is on testosterone or T for a number of years, and they have the atrophy of the vagina, and they need to get a hysterectomy to get their fallopian tubes taken out. And I brought this up in a number of my interviews because I just find it very puzzling. We're trying to treat the person, but then you come up with these various issues, right? So there's
Mhm,
an ethical concern. Now, there are many different types of treatment in the medical establishment, such as chemo, that will cause hurt and harm to the body overall. But what is the purpose of health? What is the purpose of healthcare? To bring the person to the highest form of health and well-being and wholeness that they can experience. And I think in aggregate, what we conceive of as healthy is someone who is mentally stable, as we define it. Again, that's very can be kind of convoluted when you look at the margins of what that seems like, depending on the
mhm,
society. But there's this general sense of, they're able to perform on their job. They're able to have sex, with their partner, or they're able to not involve themselves in crime or use drugs, abuse drugs. So there's a general thread of what's considered normal, and that also is intertwined with what's considered healthy.
mhm,
Religion, our social values, all of that. In the Freudian sense, the superego, we develop something to help repress certain parts of ourselves, or society will inform us what we should do and what we shouldn't based on our desires. So not every desire in itself is a pathology. Not every desire is bad, right? Like having
mhm,
sexual desire, having a desire to wear certain clothing that is maybe not traditionally masculine or feminine, that in and of itself, right,
mhm.
is not bad, right? Depending on who you ask, maybe to what extreme level people
Yeah.
may frown upon it. But non-binary, trying to treat non-binary, I don't know if I see a direct answer, from your book or any other reading apart from your book about why we need to treat non-binary if there isn't a if there exactly is an ideal life for a non-binary person, right? And I think that people just don't feel attached to it. Again, millions and millions of years of identifying as male and female, and obviously you have the intersex people, which is still a lump sum of people, depending on who you ask. And Sterling Fusto says 1.7%. Others say 0.018%, depending on the type of syndrome or disorder. So non-binary people, in the face of those realities, yes, there's abnormalities, there's different concerns for what is considered healthy, but what would you then consider is healthy for a non-binary person? Why should we have an appeal? Why should we feel sympathy for that? right? What is the
Mm-hmm.
suffering of an illness, if any? Is there an illness for non-binary people?
Yeah, I mean, I guess I don't see being trans as an illness within itself, right? And
Or just like
so
the dysphoria, or is there any?
no, no, I take more of a disability rights perspective, like a disability justice
What
perspective, that
exactly?
it's less about that there's something that needs to be fixed or is wrong with the individual, and more about
Mm,
that like broader social and cultural life cannot accommodate difference. And so
mm,
like I really think that when you start asking trans and non-binary people, why are you interested in seeking hormones or like surgery,
mhm.
it's it's less about treating an illness, and I think it's more about aligning what your body looks or feels like to how you feel in your gender,
Yeah.
right? And I guess for like non-binary people, I, I
Would that be
don't.
considered? Some people would say, well, that's kind of cosmetic. We have an idealized form of who we want to be, and well, I want to look like Madonna, so I'm gonna get a nose job. I'm gonna get my cheeks, you know, um, changed a little bit here. Pull my skin up. What What would you say to that? Like, is it something that really needs medical attention? Because when we think of medicine, we think about illness. So if
Mhm,
being non-binary isn't an illness, being trans isn't an illness. I don't think being trans, if you label yourself trans, is an illness, just to
mhm,
be quite frank. But
mhm,
having gender dysphoria seems like a very messy and heart aching ordeal to go through,
mhm.
right? Feeling like trapped and disgusted with your body, even. Um, and I do believe that there are different explanations for gender dysphoria, right? Different types of gender dysphoria that we can
Yeah.
discuss about as well. So if we want to think about that, we can come back to that. But non-binary, it just, for myself, and I think plenty of other people we've talked to, it still doesn't seem like, biologically speaking, medically speaking, there's any reason to maybe alter the body. Maybe it's something psychological. So when you bring up the
Mhm,
question, right, from your book in Trans Medicine, uh, page 79, you talk about what is the goal of transitioning. Is it to align the body with the mind, or the mind with the body? And I feel like maybe some of these more older traditionalist narratives, like Paul McHugh, right, over at John Hopkins, he's had a lot of backlash because he believes that we need to help. Most people are going to have, how do you say, desistance. So, this idea that 80 to 95% of adolescents, children who experience gender dysphoria or confusion with their gender identity, with their sex, usually have it eviscerate through puberty, and they take on their sex assigned at birth. So yeah, I think that's kind of like another talking point. But non-binary, I don't know if that's kind of where medicine has to get involved necessarily. Maybe
mhm,
that's a question that we can ask ourselves and continue in research. Like, why do we need it? Why do we need to spend hundreds of thousands of dollars on hormone treatment or even surgery to make ourselves androgynous or non-binary? Does it have to entail certain types of procedures? That's why I think as social creatures, we need categories to be able to make sense of what non-binary is, because it
mhm.
seems like non-binary means a whole host of different things to different people, right?
If you ask 100 queer people what that means to them, you'll find maybe 100 different answers.
Yeah.
But I don't think that makes being queer any less real. And I would want to be just like delicate about, and I'm not saying like you are, but
Right.
I want to be really careful about suggesting that non-binary identities are not as real as like binary gender
Right.
identities. And we do have a lot of variation in gender identification, and
Mhm.
I think it's less about that. medicine should or should not work with non-binary people. And I think it's more so about that we just need to become more familiar with non-binary people.
Mm.
Um, and I'm still just so curious about like this kind of cutoff of like,
Yeah.
if you're a binary trans person, that makes sense to access hormones and surgery. But if you're non-binary,
Yes.
and a lot of therapists like that I interviewed, they really struggled because they did think of being non-binary as like a phase, right? And it actually reminded me a lot of the way that bisexual identified people talk about how people understand their sexuality is like it's a phase and you need to choose one. Like, are you queer or are you straight?
Hmm.
Um, and so if trans medicine really is about helping patients realize in an embodied form their gender,
Mm.
then like I don't know. I don't
Right. Right. I think we're always going to be swimming in this lacuna, right, on various topics. But being non-binary is begging the question of who am I really, right? And like being male and female, we all have to ask that.
Mhm,
Being non-binary, being trans, being male, female, we all have to ask what does our gender mean? Maybe not all the time as someone who is non-binary, because they probably think about their gender a lot more. That's it. I feel like when you have a person who's non-binary, they're going to have to question that for potentially the rest of their lives, right? Whereas someone
mhm,
who is male and always is male, and someone who is female and always is female, don't have to exert that energy. And for people who associate, befriend, and make love to someone, who is non-binary, like obviously there are going to be there's going to be people who don't understand how does one make love to someone who's non-binary? How is
mhm,
someone supposed to address, someone who's non-binary? Obviously, I feel comfortable addressing Steph as they them, but that relational component of it, because when you have a black person and a white person in a room together, there's already going to be social anomalies that they may pick up, right? Like
mhm,
we won't be able to understand each other quite well
mhm,
unless if we have similarities, shared experiences. And for men and women, for girls and young boys during puberty, that's a critical point when gender differentiation takes place, right? Because boys and girls, males and females, they typically have more overlapping features pre-pubescent, and then when they go through puberty, there's sexual differentiation, and that's why you see a lot of boys hanging out with more boys and girls starting to hang out with more girls. It's a developmental thing, and so that's why I think people may bring up the thing that it's kind of like a phase. Like, for myself, considering I'm kind of like Kinsey 4 and Kinsey 3 sometimes, like there's fluidity in sexuality,
mhm,
but there's a practical element of knowing where I'm on that scale, right?
mhm,
And then also, having people understand what are my preferences obviously is going to be a little bit different when you're talking to someone who is also bisexual versus someone who has never exposed themselves to any other type of sexuality and they themselves are heterosexual and their community is heterosexual, right?
mhm,
So
mhm,
that, I would say, that familiarity and that shared experience is lacking, and that's why it doesn't seem as real. It just seems foreign. I'm not saying that non-binary isn't a real thing. I'm just saying it seems too foreign, and unless if we get those experiences of exposure to non-binary people, their values, and also how we can have certain shared values, then I think it would just be too premature of us to talk even about medicine, right, in some level, right? Because
mhm.
there's already assumptions about the binary being brought into non-binary treatment when we should be talking about just like the social implications of being non-binary before even maybe medicine.
Hmm.
Does that resonate a little bit?
Um,
It's a lot to think
I think I just disagree.
about. Yeah. Yeah. At what point? What point do you disagree, or what do you feel like needs to be added on?
Yeah, I mean, I guess like I don't know, like I somewhere in the book I think I start talking about how one way that medical providers respond to their own uncertainty, right, is that they place that expectation back on the patients, right? Like the 100% certainty. I want to make sure that you are 100% certain that you want to take hormones and that you will, once you begin them, you will stay on them the rest of your life.
Hmm.
And like I use this example when I'm teaching, right? If I said to you, Um, if I'm an admissions officer and I'm like, before I let you come to MSU's campus, I want you to tell me that you're 100% certain that this is the place for you to go to college. Like, it's an impossible burden, right? Because most people making those major life decisions are never going to be 100% certain until
Right.
they make the decision and see what happens, right? Like, so why, I guess, why do we expect that trans people all like should be 100% certain?
Right.
Because there are some trans people who, even binary trans people who might start hormones and then at some later date decide it's not right for them.
Yeah.
Um,
Yeah.
I guess I don't see that as a problem.
Right.
And I guess with non-binary people, I think it's an empirical question as to whether or not non-binary people think about gender and their own gender more than any other gendered being, right? But what I guess I do kind of see the role and responsibility of trans medical providers as offering hormones in as safe of a manner as possible
Hmm.
and leaving it up to the individual. Like, I guess I want to place the expertise over gender lies with each individual and not a medical provider and not a lawyer and not like any other institution.
Hmm.
Like, we are the experts over our gender and our bodies. So if someone's like, I identify as non-binary and I want to be on fill in the blank hormone, I guess I just don't see that as a problem.
The problem. Okay.
Yeah.
I personally think of certain problems like if someone was, again, I brought this up, but if you're taking estrogen as a man, you're going to grow certain types of anomalous features, right? That will hopefully reflect with your gender identification,
Mm-hmm.
like boobs. And, like if you want to take electrolysis, there's going to be certain types of changes, removing a body hair, whatever the changes are, some of them are permanent, some of them are going to be permanent. So especially when you start a young child, that's a big debate of the day, right? With certain senators like Rand Paul and the
Yeah.
the health committee that Biden has set up.
Mm-hmm.
There's individuals, the trans doctor on that board is advocating for children to have access to those cares. But while in the UK, they're banning puberty blockers for those who are under or below 16, right? 16
Mm-hmm.
below. So
Yeah.
there's certain types of bodily changes that can't be reversed or can't be made up, right? You miss puberty, you miss puberty. And
I mean, but if you put someone on puberty blockers and then once you take them off, they'll go
within
through.
20,
Yeah, I mean, I know it's a little different. It's like different
right?
developmentally. I guess like I don't
They
know.
won't have like like, I think my point was if you take away the opportunity to grow a full-fledged penis, they won't have enough material, sexual tissue right down there to actually create into a vagina a lot of the times, or like the depth of the vagina is going to be pretty small or low if you had adult genitalia, right? Unless if you had full developed genitalia. So there's all these different types of, I think, consequences. Again, like I talked about fertility as a big issue. Children, especially, can't make those certain types of decisions. Their children, they can't consent. That's the main argument coming from various sides. Even LGBTQ advocates too are saying like children, we need to have them think through these things, and we need to help think through these things. So obviously,
Yeah.
when you say that we're the experts of our bodies, like that's not, you're not trying to say like children need to just make rash decisions about their bodies and their development, right?
Yeah. So I guess most of the time when I think about trans and non-binary stuff, like I am thinking about
About
adults.
adults, adults.
And I do think it does it becomes more complicated with trans youth.
It does. It really does. Yeah.
Yeah. I guess like, one of the things I was concerned about, um, and we talked about this early, I think before we were recording, but
Yeah.
like I think it's a pretty bold statement in the book that we don't have enough evidence in trans medicine. And
Mm.
what I was worried about, and I spoke with my editor about this before the book went out, was like I am very concerned that someone is going to use that same argument to advocate for shutting down trans medicine, like medicine. And that's happening right now, right? Like that is what is playing out in these
Yeah.
state legislators is if you look at the argumentation that state legislators are offering, it's that trans medicine has no evidence, it's so experimental, therefore we're going to prohibit doctors from doing this. And it is in the name of like protecting the kids. um I guess though, like there might not be a lot of long-term evidence about the effects of hormones and stuff like that, but I do think that the evidence that comes out of the psychological scholarship is pretty clear, and that's, you know, preventing, and again, I'm just thinking about adults,
Mhm.
preventing people who identify as trans in whatever way they identify as trans, preventing them and prohibiting them from accessing gender affirming care has far more psychological harm than any potential like physical health risks that might manifest.
Yeah, like
And
suicide or self-harm.
yeah, yeah, yeah. So,
So we're trying to balance the immediate effects of alleviating gender dysphoria, right? We're talking about trans and non-binary people, binary trans
mhm,
people, non-binary, and then also the long-term effects. What happens if they live only to 50 because they start developing a certain type of ovarian cancer or even breast cancer, and then so what those issues imply is there's this constant tug and pull, and I think this is going to play out in the next few years still, and we're still having to answer these questions. Like your book is stating,
mhm,
it's not prescribing any certain model. It looks like, which I'm still very curious. I want to ask you about that, but
mhm.
it is stating the fact that there is a lack of clinical evidence about hormone therapy, the long-term effects of that, and the trials of experimental and controls on women taking testosterone, right? As you brought up, like what happens if we have 50 women who take testosterone and 50 who don't take testosterone, and 50 people who maybe are on a placebo, right? So like uh, something to that effect, where you're trying to control and then you're trying to experiment. What are the effects of testosterone taking? And
Mhm.
we just don't have enough robust examples of that, or hardly any, do you say?
Yeah, I mean, I don't think that clinical trial like they don't they don't exist, but they also don't really make sense, right?
They don't make
So
sense. Okay.
yeah, like I don't think you can do a randomized controlled trial because
Right, the
like
ethics
what
of it.
like what would you do, right? Like
Right, just tell a woman, hey, take this testosterone because we told you to.
yeah, yeah. So, but I think that that doesn't mean that there can't be like, pooling of data across health databases to
Mhm.
look at, I mean, because trans medicine has been going on for so long, you
Right.
can look at the consequences and the risks. But the problem is like most health databases up until recently were not tracking if people are trans. So
Mm.
I think that's one thing, like in our electronic health record. But then, like, some trans people are really concerned about that because then it becomes a privacy issue, right? So I don't know, like, it's so hard. But
Right.
I think there's enough trans people who would volunteer to share their health information for a 20-30 year period to see like what are the long-term effects of hormones.
There are a couple of Sweden studies that have shown, the tough thing about these long-term studies is that some people, like intersex populations that Alice Drager, whom you brought up, won't follow up because of the surgical hormonal ramifications, their treatment.
Mm,
So maybe they just fell off the map because they moved to another country, or there's also the shame aspect of maybe it didn't work for me. This is one of those discussion points that Lisa Littman and Ken Zucker and others have like warned about, or wouldn't say like, yeah, they would warn about this. We don't know like the full measure of people who are dropping out from these studies, and the studies from Sweden and these Dutch studies that have shown poor outcomes. Not all of them are poor, but
mhm.
these are ones that are the longest term, not just 10-year studies. 10 years is long term, but these are like 50 years from the 70s we're talking about here, right? People who have transitioned since the 70s in Sweden. one of those most liberal and accommodating trans countries, right? There is. And so they've seen that people are still suicidal. There have been lives that have been lost to suicide as well,
Hmm.
and these other negative effects. Now, I can't say definitively, is it because of transitioning? I think that there are other reasons, right? Are those mental health illnesses, comorbidities like depression, anxiety, suicide, are they being met through transitioning? And an argument could be we need to help them transition sexually and then provide that extra care, right, psychologically, so that they
Hmm.
can get on with their lives. Or is it like what Paul McHugh says and what Ryan T. Anderson says, right? They're both conservative. I don't know how they vote, or, I know Ryan T. Anderson, he's Catholic, but they're talking about how people like Walter uh, Meyer or Meyer, and he's talking about how these individuals like Walter and TWT in their book are experiencing such trauma and hurt, and they've had it since a very young age. But going through transitioning only either exasperated it at a certain point, like at first it alleviated it, and
Hmm.
then it exasperated it at some point. So now long-term studies, the point being is they need to be done. And you brought this up multiple times, right? In page 136, you talked about you have to really contextualize this as weird medicine. We're using non-FDA approved drugs in some instances in non-FDA approved ways. So when you say that, like obviously there are certain types of bureaucracies and certain gatekeepers that we need in the medical establishment. That's why I feel a bit antsy when you say that we should allow the patient to make those decisions because, well, patients don't practice medicine. They don't know all the long-term um, effects of medicine, or scientists. If they're not scientists or medical practitioners, those people should be educated on the effects of hormones and surgical interventions as well as therapy. So I think that's why there is such gatekeeping, right?
Hmm. I mean, to some extent. So, like, the therapist, like, therapeutic involvement in trans medicine, like, really started out of, I mean, it started in the 60s. And in some ways, it was kind of a cover your ass strategy for physicians, right? Like, they wanted to make sure that trans people weren't delusional.
Mm-hmm. Yeah,
They
we've
were
done it.
yeah, because to their ears it was a little out there, right? Like a patient
Right,
comes to you and
right,
is like,
totally.
I identify as a man, but
Yeah,
I look like a woman. Like,
yeah,
for a lot of people in that time period, they were just like, I don't,
totally.
whoa.
Yeah.
Um, yeah, so I don't know. I guess, like, when trans folk are on hormones, it's not like you just in perpetuity get hormone prescriptions, right? Like, a lot of doctors will ask for patients to get annual blood labs, to check to make sure that, like, all vital organs are working in the ways that they should, and cholesterol and, like, blood counts. Like, so there is a level of medical surveillance in trans people's lives in getting.
And you believe that's good?
I think at this point, because there's still uncertainty about, like, the long-term effects. Yeah. And
Oh,
for
yeah,
me, I don't particularly like medical surveillance, but I do like knowing if my cholesterol is getting a little high, like maybe over the next year I can work on, like,
totally.
like lowering
Yeah.
it. So I do think I wonder actually if people had access to healthcare, if everyone could get annual blood labs, like if that would help catch certain things, right? Much more quickly. So
Yes. Yeah. So there is the healthcare institution that we have currently, and you know, even in the Obama era, they did not allow gender dysphoria to be treated in their policy, right, in the Obamacare and so forth, because there was a lack of evidence that it supported better mental health outcomes.
mhm.
So now we've gotten, past that, and even the Trump administration, they were maybe mandating that gender and sex are the same thing, right, in some of their language, as you even written in your book.
Mhm.
Don't you feel like there's, because of the confusion, because of the uncertainty, as you have said, you have a fear of people saying that this is just baloney, like we need to move away from gender being just something that you construct completely out of your own whim or your own feelings, and focus on transitioning people who actually really need it, maybe. And for people, really, really need it, that's something that we're debating about, right? And
Mhm.
then also the idea of sex being so differentiated from gender. Personally, I have my reservations about that, because when we're talking about gender dysphoria, we have to keep in mind that there are some unknown causes, but then certain causes that other scholars like Michael J. Bailey, and he is a notorious figure in some ways, right? Because of his views that gender dysphoria is not just simply one being born in the wrong body, right? That's the narrative that people kind of spout in public media and popular mainstream media. And
Mhm.
his ideas, his taxonomy is really taken from another social scientist. And trans activists that I know have kind of hounded them because they say this thing that sexuality is also a reason why people transition, right? Homosexual male homosexual trans individuals. So people who are male homosexuals, they want to be with a straight guy, and why not? He's not saying that people shouldn't transition. He's just
Mhm.
saying why not? They have a sexual orientation and they want to live that out. They can transition, right? And he's not pushing anyone to do it. It's like you should do it. Yeah, let's go for it. He's just saying like if that's really their values and they have certain challenges of being a feminine gay man because gay men like more masculine gay men typically. So the lack of sexual capital between straight guys and gay men, maybe it's best for them, to actually transition so that they can be a trans woman and have a happy sexual lifestyle. And then there's that autogynephiliac uh, subtype of the trans individual, which Anne Lawrence talks about. Anne Lawrence is a autogynephiliac subscribed anagonophiliac, and anagonophilia is the love of self as woman. So there's a type of sexual component to it where one likes oneself as a woman. So there's an arousal to that, and people on YouTube have posted videos about them sharing their experiences about that, as well as Anne's book, Men Trapped in Men's Bodies. So I think getting beyond the gender identity crises, right? What are the actual experiences, as you have alluded to in your book here, and those writers who are different in their approach, right, in their taxonomy of trying to classify what gender dysphoria is. You don't do it explicitly here, but you talk about the ramifications, right, on the medical authority side of things. How do we treat trans people's bodies? And that goes hand in hand, as you brought up in the passage that I read from in page 79 about what are we treating exactly? One's mental health, their identification, right, the mental, psychological being to the body, or is it treating the body to align with the mental identification of gender?
Mhm.
Now, is
No,
there
go
something
on.
you'd like to say about that?
Sorry, what's up?
Yeah, is there something you'd like to say about that?
Oh, I guess like I've come to understand that I think the easiest answer to that question is that it's both,
Yeah.
right? And that like there's not like a trans person though. Like, so you might have some trans people who respond really positively to being on hormones. And if
Right.
they maybe also experience depression, it might be alleviated from being on hormones. And there's other people where maybe that's not true, right? And so I don't know. It is like it's a complicated question and one that is I'm going to go ahead and say, like, as a sociologist, we don't usually use the word impossible, but I'm going to use the word impossible. I think it's a question that is impossible to empirically substantiate if it's one or the other,
Hmm.
um, because there's so much variation in trans identification. So,
Right. I'll just use your words as you pen in page 168. You say, many questions remain about what the future of trans medicine may look like and how medical uncertainty can be resolved in ways other than doubling down on authority. But one insight becomes clear: trans medicine is not a linear story of progress. There are new challenges that providers face in this medical arena and unanticipated sources of uncertainty. With the introduction of non binary people seeking medical interventions and a growing population of trans youth, the tools that medical providers have to work with trans people may not easily translate into alleviating these new forms of uncertainty. That is seemingly an impossible battle, right? As you
Mhm.
say, how are we supposed to treat our trans patients, our trans family and friends on a social level, but apart from that, on a medical level, right? Changing, altering their bodies, their hormones, so that they can feel whole as an individual or reflect their gender identity.
Mhm.
That's a question that we will continue to ask, like others, say Ryan T. Anderson, Lisa Littman, Leslie Stahl on the 60 Minutes interview recently. There has been a growing number of people, as you alluded to, young children who are growing up and feeling like they don't belong in their bodies. And then there's LGBT groups. Actually, one in particular, I think about LGB Fight Back. So they're someone who is trying to drop the trans label, right, from LGBTQ, which is really, really, uh, yeah, very, very contentious, to say the least, right? Because the question is, are our medical establishment transing gay and lesbian people away, right? Are we so fixated on the binary, which I believe we are, again, coming from more conservative leaning, and then you know the
Mhm.
biological ideas of, well, millions of years of male and female. How are we supposed to get rid of that? Because I really want, if people can live a healthy and functional life as another gender, then we should support that in whatever way. But I'm saying that there is going to be certain types of barriers, and I know you yourself are non-binary. There's going to be social barriers. There's going to be different types of biological barriers, right? That's why we seek treatment, whether it's
Mhm.
an illness or not. We seek
Mhm.
treatment, and when we have the confrontation of non-binary and then young people transitioning, right? Are we doing away with puberty, right? Because puberty does solidify sexual development and identification with one's gender. These are questions that need to be asked, and you are asking them. So thank you so much, Steph. I really appreciate you coming on and just having the discussion. I know that there's just so much that I want to talk about. We will definitely have to set up another time privately, or maybe in the near future, you know, you come back onto the podcast and talk about it. But what do you hope people get out of your book and promoting these ideas, promoting these questions?
Yeah, I mean, I think that what medical providers begin learning as they work more with trans people, in spite of all of their uncertainties, all of their fears, is that it was right at the end of the time with providers. And so I was aware that I was mostly asking them about like what challenges come up, how do you deal with that, how do you make decisions? And so I started asking them like what were things that came up in working with trans people that they thought were positive or that like and so then they started talking about, well, yes, there are a lot of uncertainties and challenges, but the more that I work with trans people, I actually feel like I become a better doctor
Mhm.
in general for all of my patients. And I thought that was really interesting. So I was like, well, tell me more about that. And, you know, they talk about how for like one example is because of all of the medical mistrust that trans people have when they go to see healthcare providers, that providers feel responsible for kind of taking more time to build rapport and establish trust with their patients, and they really get to know their patients. And then they're like, wow, I actually want to do this with all of my patients. I want more time with my patients, right? And I think we know, if anyone's been to a doctor like in the last 10 years, that usually it's like a 7 minute in and out, right? Like, why are you here? How's it going? What was the last year like? Anything that you're concerned about, all right, check, 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 get out, because I have to go see the next patient. And so providers were talking about how working with trans people helped remind them why they got into medicine in the first place, and that is to become involved in the lives of their patients and get to know their patients and help them and heal them. And so I think that for doctors, yes, I acknowledge there is a lot of uncertainty, and that's shared across a lot of providers who work with trans people, but there are also unanticipated advantages of working with trans people, right?
Mhm.
Um, and I think also, there can sometimes be a little bit of a tendency to think about like trans medicine is so out there, like it's an outlier, right? But the uncertainties that providers experience and how they manage that, I think tells us more about medicine in general and
Hmm.
how their responses are patterned. And in some ways they should be expected, right? When we think about novel medicine and how providers respond to that, at first it's usually not well, right? Because it challenges their sense of themselves as experts. Like, let's go back to COVID-19
Right.
in January, February, March, and like they eventually figured out some strategies for mitigating that uncertainty and started moving forward in decision making. So I think that like trans medicine does have some distinct characteristics. One of them is like the gender identity component,
Right.
but it's also, we can see threads of how the medical establishment responds when we can, like, in making comparisons to other marginalized groups. So
Mm. There is room for improvement, and
mhm,
we are dialoguing, we're talking about it, we're doing our research, and hopefully more of that turns out in such a way that hopefully humanizes trans individuals
mhm,
and really helps us understand what trans people go through as well as
yeah,
a true category. And that's your hope. I hope that we have been doing that here on Outed. And for those who are watching, get in touch with Steph, get a hold of their book and Trans Medicine, the emergence and practice of treating gender. This is a book that will definitely have you thinking and questioning through what is the medical establishment really ought to do and the authority of it, as well as how we treat people that we love and care about who are trans as well. So, Steph, thank you so much again for joining me here today to have this really intense topical discussion on the treatment of gender. And I can't wait to hear about the progress that you do in your research as well as the sales on this book. So, thank you.
yeah, yeah. No, thank you for
Yeah,
having me. So.
my pleasure. This has been John Chen here on John Chen Outs the World, here with Steph Schuster. I hope you have a great one.